So we have Dr. Shweta Bansal. Very excited to have her again. Shweta Bansal is a Provost Distinguished Associate Professor of Biology at Georgetown University and specializes in modeling for infectious diseases. She is trained as an interdisciplinary applied mathematician and disease ecologist from the University of Texas at Austin, and was a fellow of the prestigious Rapid Doctoral Program, which is of the U.S. National Institutes of Health and the Department of Homeland Security. At Georgetown University, she leads a research group that develops data-driven mathematical models at the interface of social behavior and infectious disease dynamics using tools from network science, statistical physics, computer science, and statistics. She is a 1.5 generation immigrant and hails from the San Francisco Bay Area.
Thank you so much, Jessica. Can you all see my slides? Yeah. Yep. Awesome. All right. Thank you so much, and thank you all for being here. This is, to say that this is a challenging time, I think, is the understatement of the millennium. And so, I especially thank you all for being here, for being present, and really nothing gives me kind of more hope at the current moment than getting to talk to what will be the next generation of infectious disease researchers. So really, glad to be with you all here. I was going to introduce myself, but just took care of that. So thank you for that. What I'd love to chat with you all about today is kind of work that I've been doing since graduate school. I sort of got very lucky in some senses. I didn't go to graduate school for doing infectious disease modeling, but just I went to do mathematical biology of some type, but just found a lab that was applying mathematical modeling to infectious disease problems, and I fell in love with sort of how cool the math was and how impactful the science was, and how you kind of had to be a Swiss Army knife to do work in this field, and that's, I just loved everything about that. So what I worked on for my PhD was network models, and I know you all have heard about lots of different types of approaches over the last day or so. So I'd love to just tell you a little bit about network models now. This won't be kind of comprehensive in any way. But I just want to give you all the taste of kind of what these models are, what they can do, and hopefully you can keep them in the back of your minds as you kind of carry on with your career and go become, hotshot researchers and physicians and public health practitioners and mathematicians and physicists and everything under the sun. So just some things to keep in mind. So I will try my best to leave time at the end for questions. So please jot things down kind of as they're coming to mind, or you're welcome to ask as I go through. So to get started, I'll flesh up the compartmental model that either you saw before today or before this weekend, or something you've kind of become familiar with over the last day or so. Really, the entire field of network epidemiology, which is what I'm talking to you about today, was inspired by kind of how compartmental models were being used and an assumption they were making. So a significant assumption that compartmental models make that I'm sure you've all heard about is homogeneous mixing, right? That they assume that everyone in a population interacts with everyone else in the same manner, and that they can infect each other in the same manner. But what we know from observing real populations, whether they're humans or animals, is that infectious disease risk kind of tends to really vary in the population. Different types of individuals interact with others in different ways because of their age and their culture and their occupation, and whether they live in an urban environment or a rural one, and about 100 other things, right? And so there is a lot of variation in kind of what behavior looks like in a population, and that behavior is fundamental to disease transmission, as we've learned over and over and over the last couple of years. So really the fact that compartmental models weren't capturing this heterogeneity is the reason we really network models really took off. And really, it was the last time we had a SARS pandemic, which was the spring of 2003, really is what kind of gave us a real obvious kind of textbook example of how network models would be useful. So in the spring of 2003, two individuals, before the pandemic started, in the early stages, two individuals were infected with SARS, what we're calling SARS-1 now, kind of left Hong Kong and both went home to Canada. There was a person going home to Vancouver, and they didn't infect anyone else once they got there. Whereas the second person was going home to Toronto and ended up leading to about 200 cases just from that one individual. And so this kind of case really highlighted that disease outcomes kind of do very fundamentally depend on individuals and their behavior. So it turned out that the Vancouver man kind of lived at home by himself. As soon as he had symptoms, he sought care, went to the hospital, was isolated, and didn't, that particular epidemic tree was kind of contained. There was no transmission from there. Whereas the Toronto woman that went home was part of a multi-generational family, really kind of was at risk for infecting a lot of others, interacting with a lot of others. And so that, really turned into an outbreak. Now, a compartmental model would have just predicted the same outcome in both of these scenarios. So really needing to capture that variation that exists in behavior and social structure is really kind of what gave us motivation to really develop network models. Now, that's not to say network models kind of are new to, and were only developed since 2003. I'll show you examples in a minute that, where network models have been kind of used since before then, but really the field's really taken off since then. And so the field that I keep referring to is called contact network epidemiology. And really, like any other kind of disease modeling field, right? It's really a method by which we can take basic science, our understanding of how pathogens spread, how they interact with the host immune system, to kind of take a bunch of that understanding and any available data about how a disease is spreading and turn that into both new scientific insights, but also policy advice towards specific policy questions. What's a little bit more unusual about network epidemiology, though, is that it's an even more interdisciplinary science. I think all disease epidemiology or disease modeling is interdisciplinary, but network epidemiology is like particularly interdisciplinary, where it borrows tools from a bunch of fields like computer science and statistics and math and physics, but it also kind of really connects in tons of cool ways to fields like geography and sociology and demography and psychology and econ, and that list really kind of continues. So again, this is something I really enjoy, and something if that's something you enjoy as well, networks are maybe going to be your cup of tea. So how have kind of networks been and networks epidemiology been used in different ways? So I certainly can't get all the examples on one slide, but just to kind of give you all a flavor of what all the different ways are. So certainly networks can kind of help us think about invasion dynamics, right? So when a pathogen newly emerges in a population, kind of where will it go from there? What will it do? Will it infect just one or two others and fizzle out, or will it really erupt into large outbreaks, right? It can also, network models can kind of also really help us take under our understanding about social structure or social policies, and help think about kind of how disease might spread in a given population. So this is a case with where network models have really had a lot of success thinking about sexually transmitted disease transmission, and really thinking about how sexual behavior in a population and social structure really kind of can drive transmission patterns the way we observe them. Networks have also been used for things like livestock infections, where networks don't have to be used at a particular scale. You can think about them at very, very large scales, so they're very versatile in that way. And they've been used, of course, I think, as we all sort of ultimately want to be able to use our models in infectious disease for thinking about public health or animal health interventions. So the example I'm kind of citing here is thinking about kind of hospital infections and how connectivity between different parts of the population within the hospital can really affect transmission patterns, and how we can kind of, all manipulate that to decrease transmission over time. So let's then think a little bit about network epidemiology basics. Maybe this is something some of you have come across. Maybe this is new to you. So essentially, thinking about networks for the purposes of disease spread, we essentially have to start with a host population, right? This is true of any other disease model. With that, the next step we need to do, which would be different than if you were thinking about a compartmental model, is that you'd have to really explicitly think about how different individuals within that population kind of interact with each other. And when I think about interaction here, I'm really thinking about contact that can cause disease transmission to occur, right? So that for a respiratory disease, that's going to be, distance of a particular, or maybe 6 feet from each other. For a sexually transmitted disease, that might be sexual behavior. Since my photograph here is for an office setting, let's assume that we're talking about a respiratory disease, and not try to think about other transmission modes here, right? And so for this population, really small, simple example of 5 individuals, right? My network has 5 nodes, right? Which kind of each of these nodes represent an individual, and an edge between 2 nodes represents a disease-causing interaction of some type, where if one person at the end of an edge were to get infected, they would have the possibility of infecting the person they're connected to, right? And what's kind of cool about networks is that they really fundamentally kind of capture this notion of contact, which I'm sure you'll all agree is absolutely critical to transmission happening. If there's no contact, there's no transmission, right? And so networks kind of really explicitly capture this, and they can be summarized very simply, right? So, for example, there's a characteristic of every node in a network that's called degree, which basically counts the number of edges that node has, right? So if an individual has a degree of 2, it means that they're connected to 2 individuals. From a disease spread perspective, this is really useful information already, because we know that individual has, compared to everyone who has a degree of 1 in this network, they have a higher risk of both being infected if they're susceptible, or infecting others if they become infected themselves, right? And so together, these kind of features play out really nicely as they can kind of capture different types of individuals in a population, right? Where you might have somebody working from home in your population, where they maybe don't have a ton of disease-causing interactions in a day, versus somebody like a healthcare worker that has tons of interactions in a day by which they can get infected and infect others. Network models can sort of also capture a lot of different types of relationships and interactions, right? So that interaction with, the person sitting next to you on the bus might be very different than the interaction you have with a family member. So the ability to kind of capture all of those in one place. And these are models that can kind of capture even more information about the contact that we probably won't have a ton of time to talk about today, but I'd be happy to say a bit more later. So, so we'll kind of walk through how one develops a network model and how one uses it. But really the idea here is that you can either start with data that tells you about the behavior of your population and kind of use that to make disease predictions. And once you have disease predictions, you can then explicitly think about public health control strategies. And really this slide is essentially meant to summarize kind of the 3 steps we'll go through, right? So we'll talk about how one starts with data, and develops a network model, how you then use that to make disease predictions, and how you might then use that to make think about control strategies, right? So starting with the first step of network data and generation, right, we can kind of think about building contact networks in a few different ways, but this step is kind of critical to doing network epidemiology. And again, it's a step that isn't at least explicit when you think about something like a compartmental model, right? With a compartmental model, there is some implicit idea of how individuals are interacting, but you just don't tend to be as explicit about it as you need to be with a network model. So there's a few different options that allow us to kind of build contact networks, right? They kind of vary in how realistic the model is. So to start off with, I'll kind of start with what are called idealized networks, right? And so you'll see on here a few examples. So there's graphs or networks called random graphs, or one's called small world graphs, right? Essentially, these are all networks that don't necessarily rely on data about a given population, but they just have particular structures. So they're essentially useful for carrying out controlled experiments in contact network epidemiology, right? So you might say, what happens if my network has a structure like this? If my population has structure so that pretty much everybody in the population kind of interacts with the same number of individuals, what does disease spread look like in that population versus a population where there's a lot of variability in how individuals are connected to each other? So maybe most individuals in the population kind of just interact with one or two others, whereas you might have like some hubs in the population where they have just a vast number of contacts, right? Kind of distinguishing these two types of network structures and thinking about how disease spread might happen through them kind of gives us a lot of generalizable information, general information about how network structure impacts disease dynamics, right? How the way a population interacts can impact their disease dynamics. And so again, right, these are not based on like particular realistic populations, but really just help us come up with general insights about populations and disease spread. On the other extreme are sort of empirical networks, right? So these are networks where you start with data and really kind of build up the network a little by little with an understanding of every single individual in your population, right? So this is an example from a sexually transmitted disease study where they identified 22 IV drug users and asked them, essentially interviewed them by asking them about their sexual contacts. And so each edge here was a reported contact in an interview by an IV drug user, right? You can imagine this type of data collection is both quite resource intensive, but also can have a lot of ethical constraints. And so more recently, in more recent sort of years and decades, researchers have started using sort of device-based methods to kind of collect network data about our population. So this example comes from a high school where there were 700 students and staff. And essentially each student and staff were given what's called an RFID tag to kind of wear on a lanyard around their neck, and they kind of went about their business in a normal school day. But those tags, those devices around their necks were kind of recording who they were coming into close contact with. And that resulted in this type of data, right? So already we can kind of do this type of work in much bigger populations than you could if you were interviewing individuals. And so, either by kind of building contact networks, through data, or by building them sort of more mathematically to have certain properties, we can kind of have a very explicit description of what a population is and what their, kind of pathways of transmission might be if a disease were to be introduced into that population. So now that we have a network, we can kind of carry on and think about disease spread in this population. So this is, again, very similar to kind of what we do with compartmental models. It's just here, there's a very explicit, again, definition of what the host population is and what all their interactions are. And we have, very similar to compartmental models, we still have information about the pathogen that we need to put in, things like the infectious period of the pathogen, the susceptibility that hosts tend to have, the infectivity level for anyone who is infected, what their transmissibility is for that given infection, for that given pathogen. And once we have that information, we kind of feed that through a disease model. I'll give you a couple of examples in a minute. And again, we make epidemic predictions based on that, and eventually be able to think about interventions, right? So essentially, there's kind of two big categories of models that I'll tell you about. Unfortunately, we won't get a chance to kind of dig too deep into it today, especially because I want to leave time for questions here at the end. But anyone who wants to hear more about them, I'd be happy to say more, right? But essentially, the first type of, first category of network models that kind of help us explicitly think about disease spread on networks are analytical disease models, right? This is, is going to look very similar to what the compartmental models you've already seen are. So this is the, a version of a compartmental model that, you've already seen. Again, this one assumes homogeneous mixing, but we want to, take into account, again, that there's variability in our population that is represented by our network. Okay. And so instead of having this equation look like this, where everyone in the population has that same beta and that same risk of getting infected, we would have an equation that looks like this, right? So this model is still very much based on equations. This is why it's called analytical. But instead of just having one equation for every single infected person in the population, essentially what we're doing here is breaking up the population. So I'm going to keep track essentially of infected individuals who have just one interaction or one contact, separately from infected individuals who have 2 contacts versus 3 versus 4, all the way to the maximum number of contacts that any individual has in this population, right? And so now, instead of just having one equation, maybe I have 20 equations, because the max number of contacts in my population is 20. And so this has grown mathematically into a more complicated problem for sure. But the beauty is that we're able to kind of take more information into account. And based on this, we can kind of, again, predict incidence over time, just like we would in a compartmental model, but just we're taking into account a lot more of that information. And from that, we would predict things like, how many individuals got infected at the end, how many individuals got infected at the peak of the epidemic, how long did the epidemic last, right? Standard things that we tend to measure from any sort of disease model. So the advantage of analytical disease models is that they are simple to kind of write down. They, really kind of look very familiar if you're familiar with compartmental models. But the, kind of disadvantage is that they can only take a portion of all the information that goes into a network, right? So in this case that I highlighted here, all we were taking into account is how many individuals there are in the population with 3 contacts versus 4 versus 20, right? We weren't taking into account who was actually connected to whom, who was actually able to transmit to whom, right? And so the sort of alternative to analytical disease models are simulation-based disease models. These are often, so the example I'll give you is a discrete time simulation, right? And this is a type of model where you kind of take all of the network information into account in all its glory, right? So here, if my network kind of looked like this, I would essentially mimic what disease spread might look like. So I might start with a patient 0 that's infected, at random in this population. And then I would look at who in the population this patient 0 is connected to, it has interactions with, right? So it's these 4 individuals. And so at the next time step in my simulation, I might figure out that these 2 individuals out of the 4 contacts this patient 0 had get infected. That's what I'm denoting with this red filled in circle here. And then at step 2, maybe our patient 0 has recovered because they've gone through their infectious period, right? But because these 2 individuals are now infected, they're now infecting their contacts, and so on and so forth, right? So I just kind of actually simulate, I actually mimic the steps of disease transmission in a population one by one, taking each infected individual into account and kind of looking at who they might possibly infect, right? And we kind of let this keep going till we run out of infected people in your population. And again, this kind of allows us to look at things like incidence, how many people got infected, what the duration of the epidemic was, and so forth. But the other advantage here that we didn't have on the previous slide is that we can run this scenario over and over and over, right? So the fact that this individual, this patient 0, only infected these 2 contacts, but not these 2 contacts, could just be a matter of chance, right? So models like this kind of take that stochasticity, that randomness into account. So you could essentially do this process once and get one of these curves, and then you do it again, you might get a slightly different curve. And you could do it maybe 1,000 times and have a whole bunch of scenarios that could possibly happen. And we can maybe look at the average of those scenarios, or we can look at that entire range of scenarios where this gray, very light gray line, right, looks very different than the one all the way on the left here. And both of those are likely scenarios in the same population with the same pathogen, which has the same characteristics, right? So capturing that variability, capturing that stochasticity ends up being a really, really useful tool, okay? So let me then move on quickly to kind of thinking, now that we have a network, we have a means by which we can predict disease spread in it, right? We can simulate disease spread in it maybe. We want to now start answering some very practical questions about interventions, about control strategies, right? So we can do that in a few different ways with networks, right? And again, it's really just about kind of thinking about what our intervention is and mimicking that on our network, just like we thought about what disease transmission looks like in a population, mimicking that in our disease model. So essentially, we can kind of think about 3 types of interventions, right? One set might be what we call transmission reducing interventions. So these are your face mask wearing and washing hand behaviors, again, that we've all become very, very familiar with, right? To mimic that on a network, we might take our original contact network that has all its edges, and instead of allowing all edges to kind of transmit infection, we maybe allow only some edges to transmit infection, right? Because if you're wearing a face mask, let's say you're wearing it really well, it's an N95, it's really, really effective, right? That edge essentially isn't going to be able to transmit infection anymore. So you might, allow disease spread on this original network, essentially as the control in your experiment. And you might alter this network based on information about the intervention, and again, mimic disease spread on there, and then compare the 2 to figure out how effective the intervention was. Now, on the other hand, if you have a different set of interventions like quarantining and school closures and social distancing, I don't think any of us want to hear those words again for the rest of our lives, but here we are. This is the field we've chosen, so we're gonna keep doing this, right? In this case, right, instead of edges in the network changing, right, we're saying that instead of the edges just becoming, less likely to transmit, essentially we're talking about just removing edges from the network, right? So if this individual here in the center was a school child and their schools were closed, then maybe they wouldn't have interactions anymore with their classmates or their teachers, right? Which may be these 2 nodes. And so again, we can mimic that by essentially changing the network, by removing those edges from the network, simulating disease or thinking about disease spread on this control network and on this intervention network, and comparing the outcomes to say, okay, this intervention is this effective, okay? So I'm going to actually skip ahead. So I want to leave you all in sort of the last 5 minutes or so with a couple of examples of sort of how network models have been used to address particular sort of intervention strategies, address particular public health problems. So the first example actually comes from flu. But this is very much a problem that we've been facing with COVID as well. And so the problem essentially is that with flu vaccination, often there's a lot of shortages. And so there's a debate that's been kind of going on in the public health field about whether it makes sense to protect directly those individuals that are most at risk from severe outcomes from flu, which tend to be elderly individuals and infants, or whether it makes more sense to vaccinate those individuals that are most likely to spread flu, which happens to be school children and sort of younger adults that are kind of out in the and employed and kind of interacting with a large number of individuals. And so for this problem, a contact network that kind of captures ages in the population is a great way to sort of address this question, right? So essentially, again, you start with a network where you have ages. Each individual has their number of contacts that maybe depends on their age, and you take that original network where no one is vaccinated. You mimic disease spread in it. And then you go back and you kind of look at each of these strategies and say, okay, in the one case, I'm going to vaccinate school children, by which I'm going to just alter the network to mimic vaccination. Again, I'm going to simulate disease spread on that network and look at the outcome. And I'm going to compare that to what happens if I instead vaccinate elderly individuals, right? And so by doing that process, you can kind of come up with a public health recommendation. And it turns out that the optimal strategy is really depends on kind of how transmissible the disease is, how contagious the disease is. But my recommendation certainly in this case is to be prudent. Let's just make sure to use the risk-based strategy so that we can directly protect those most at risk for severe outcomes. So this debate probably sounds really familiar since we've had it repeatedly with COVID over the last year. Another example is, on a much larger scale, where instead of having network nodes be individuals, we can think about network nodes being communities across the country, right? So where maybe, let's say, every county in the United States is a node in a network, and each county is connected to another county based on mobility, for example. Right, where individuals interact with others in other communities because they commute for work or they go across county borders for shopping or other leisure activities. Right, so we can kind of think about what that network looks like, and think about, for example, how the country should really be kind of regionalized for thinking about like resource allocation. Right. If this part of the country is kind of more connected to other neighboring states, then let's kind of treat them as one whole, because most likely they're going to have infectious disease dynamics that are synchronized and that look similar to each other, versus maybe this part of the country. The map ends up looking from this model ends up looking a lot more complicated than this. This is just a kind of cartoon that I have here, but the really kind of thinking about the network connectivity between communities can really help us address a whole different set of public health questions as well. All right, so I'm going to kind of wrap up here, and what I'm going to do for my wrap up is kind of think about what my wish list would be for an awesome disease, sort of infectious disease model, right? So, and this wish list might look different for different people, but at least for me, right, I want a model that kind of captures the salient features, the most important features of a host pathogen system, right? I don't want extraneous details in there that aren't going to affect the process that I care about, which is disease transmission. I wanted the model to be versatile, because public health is a fast-moving area, and the problems change very, very rapidly. So I want my model to be able to kind of, be adapted to different populations or different settings really easily. I wanted to kind of play well with other models or with data. I wanted to produce kind of insights that aren't just specific to that particular population in all its details. I want to learn something general from it that I can apply in a much larger context, because if I spend, $100,000 developing a model for something for one very tiny population, and I haven't learned from that for other populations, then that's not a great use of resources potentially, right? And lastly, this might not be on a lot of other people's wish lists, but I want my model to be intuitive, right? I want it to be, easily explainable to both policymakers and the general public, because I feel that that's a really important feature for models, being able to communicate the findings from them. And so this is sort of my wish list, right? And it turns out, biased opinion entirely here, folks, but it turns out that network models actually really fit the bill in a lot of these characteristics that we might look for in an infectious disease model. So just sort of something to consider in the future if you are thinking about modeling certain systems yourself. So I will wrap up here. I'm going to throw up a quick photo of my amazing group, right? These are the young people that kind of keep me going and do amazing science, and and I'm excited for all of you to kind of be joining this field, and in particular, if you're interested in kind of joining us at Georgetown University, I'll leave these programs up. So we have a PhD and a master's program in global infectious diseases that focuses both on policy and the science and the modeling of thinking about infectious diseases. And we have a graduate program, a PhD program in biology. So with that, I will wrap up. And if there's questions from you all, I'd love to answer them.